So I'm going to be giving a talk later in the conference where we've undertaken a research program looking at how we can really try and improve how the patients are experiencing red cell exchange transfusion. So this is a treatment that's commonly given for patients who've got sickle cell disease. And we know that recently there's been a number of new novel agents that have come through, but unfortunately they're not meeting the criteria yet to be funded by NICE. And so we're still in the position where we have some very old but well-established treatments to give to patients. So red cell exchange transfusion is one of these that we know is really well validated, particularly in the pediatric environment where we know it prevents secondary strokes. But it's also really useful in our adult care setting where we commonly see patients needing this treatment in order to prevent them from having recurrent episodes of crises. So we wanted to see how we could improve the patient care of the population that come through the therapeutic apheresis unit in Oxford. We did this in two ways. In the first instance, we conducted a survey of the people who were coming regularly to our service just to ask whether we could do things better. And we asked an array of different questions. Some of those questions showed that actually you could see a real improvement in patients' chronic symptoms of pain and lethargy immediately following their transfusions. But they did have some concerns and they would like a few things to be made better. So the things that they particularly focused on were improving, reducing the frequency that they had to have their treatments, and also trying to improve the availability of blood, so trying to speed up and make that more of an efficient process. So we took that and we tried to then conduct an audit of 22 months of people who had a red cell exchange transfusion in our service, and we looked to see whether or not we could try and predict how many units of blood patients were going to need. As a part of this, we did a baseline assessment of how we were doing, and we had the process at that time of ordering 25% extra for the patients, just in case, so that we didn't have patients going without an adequate amount of blood. But this meant that these are very valuable units that were potentially not being given to the right patients, or the most effective use of those units. So looking at the variability of different parameters that are important for predicting how many units of blood each individual will need for an exchange transfusion, we identified that the hemoglobin S percentage was the most variable. And so we tried to build a predictive model looking at a whole bunch of different variables to see whether or not we could find out what the hemoglobin S percentage was going to be at a given time in the future. We were able to identify that this is really dependent on each individual patient. There seemed to be quite tight clustering between episodes of one patient, but that could be very different to another. And so we have found that there is definitely a linear association with time with the accumulation of hemoglobin S in the windows that we were able to look at, but we need to get more data to get some more confidence in being able to predict this in order to make it our primary source of choosing the number of units for patients in the future.